In this lecture, we will discuss T-wave changes in acute myocardial ischemia, including a review of normal T-waves, isolated T-wave inversion, as well as ischemic and non-ischemic T-waves. The T-wave is known to be generally difficult to discern whether it is normal or abnormal on the EKG. If you recall, normally the T-wave is concordant with the QRS complex, meaning that it goes in the same direction as the main vector of the QRS complex. If they go in the opposite direction, that is discordant, it is generally considered abnormal. The T-wave is typically positive in just about all leads, except for leads AVR and sometimes V1, in which it is negative, and so is the QRS complex, so meaning they are still concordant and normal. Okay, so again, normal T-wave, here's our T-wave again present. Notice that it's positive upright, okay, in the same direction as a positive QRS complex, okay? Both positive or upright, or mostly positive, so that's what we mean by concordance. The main vector of the QRS complex is in the same direction as the main vector of the T-wave. Now, as we've mentioned in previous lectures, the transition between the ST segment and the T-wave should be smooth. The amplitude should not exceed 5 millimeters in the limb leads and 10 millimeters in the precordial leads. T-wave amplitude tends to be greatest in leads V2 and V3. The T-wave amplitude is typically proportional to the QRS amplitude, and remember that normal T-waves are asymmetric, with the slope of the descending terminal portion being slightly steeper or more rapid than the initial ascending portion. Okay, so that's your basic recap on normal T-waves. Now to the fun stuff. Okay, so as you probably are aware by now, T-wave abnormalities can occur in a number of conditions other than ischemia, which can make interpreting them difficult. Moving forward, we'll try to look at some of these abnormalities to see if we can clarify some things. Let's start with the inverted T-waves, or T-wave inversion. This simply means that the T-wave is negative, and we define whether a T-wave is positive or negative by the terminal portion of the T-wave. So with T-wave inversion, this should mean that the terminal portion of the T-wave is below baseline. Okay, so here you can see a T-wave. Okay, this is our T-wave here. Notice it's below the baseline. Okay, again, you can see in this case, here's T-wave inversion. Our T-wave is below the baseline. Okay, now sometimes you may come across a biphasic or diphasic T-wave, in which the T-wave has a positive and negative deflection. First of all, biphasic T-waves carry no real clinical significance. And second of all, remember, we define a T-wave as upright or inverted based on its terminal portion. In other words, if the terminal portion of the biphasic T-wave is positive, then it's considered an upright T-wave. If the terminal portion of that biphasic T-wave is negative, then it's considered an inverted T-wave. Okay, and you can see these biphasic positive T-waves and biphasic negative T-waves. Okay, remember, you can see here it's a negative and positive, but we define it by the terminal portion, which is this one, which is upright. So we call that a positive or upright T-wave. Okay, and here the terminal portion, here's positive, but the terminal portion is negative. So we call that a biphasic negative T-wave, which is simply T-wave inversion, or a negative T-wave. Okay, so remember that we define these T-waves by the terminal portion. Okay, now T-wave inversion is graded according to its amplitude or depth. In strict terms, T-wave inversion refers to T-waves that are 1 to 5 millimeters deep. Deep T-wave inversion refers to T-waves that are 5 to 10 millimeters deep, and gigantic T-wave inversion refers to T-waves that are greater than 10 millimeters deep. Now it's important to be aware that myocardial ischemia may present regardless of this T-wave depth. In fact, myocardial ischemia may be present with flat T-waves, which are defined as T-waves with an amplitude between +1 and -1 millimeter. So 1 millimeter above baseline and 1 below. Okay, and here's this T-wave inversion grading. Okay, and it's based on the depth. Okay, these flat T-waves, as you can see here, here's a flat T-wave. Okay, it's between 1 millimeter above and below baseline. Okay, when we talk about T-wave inversion, just regular, that's from 1 to 5 millimeters deep. Okay, so if you looked here, this would be a T-wave inversion. It's between 1 and 5 millimeters deep. Deep T-wave inversion would be if it went all the way down between 5 millimeters, so maybe between 5 and 10, and then gigantic would be greater than 10 millimeters deep. Okay, so that's just some nomenclature, not too difficult, but if you want to know the strict grading criteria there. So what about isolated T-wave inversion? That is T-wave inversion without concomitant ST elevation or depression. So we only have isolated T-wave changes, okay, that are inverted, and there's no ST segment deviation. Well, actually, isolated T-wave inversion is not a sign of acute myocardial ischemia, which is a common misunderstanding. You need ST segment deviation, elevation, or depression with the T-wave inversions to be considered ischemic. The only reason you may see isolated T-wave inversions in the criteria for myocardial infarction is because the isolated T-wave inversions occurred after the ischemia has resolved. In other words, isolated T-wave inversions confirm that ischemia occurred, but not that it is still occurring. These are referred to as post-ischemic T-wave inversions and may be accompanied by negative U-wave, which actually further increase the likelihood of ischemia. These post-ischemic T-waves typically resolve within days or weeks, but they may persist for over a year, in which case they now are defined as chronic. The normalization of T-wave inversion following infarction suggests some recovery of the infarcted region. Now, there is one important exception of isolated T-wave inversions called Wellen syndrome, but we will save that for another lecture. Okay, so again, now we're looking at those post-ischemic T-wave inversions, okay, or changes. Notice here's our post-ischemic T-wave changes, and this is where you just see simply T-wave inversion. Our ST segments still at our baseline, okay, no depression or elevation. Same thing here, our flat T-waves, again, post-ischemic T-wave changes, okay? Now remember, we said that the normal T-waves are asymmetric, but ischemic T-wave inversions are symmetric and rarely greater than 10 millimeters in depth. Just like ST elevation in reciprocal ST depression, T-wave inversion will have upright T-waves in leads with an opposite angle of observation. Okay, let's look at the EKG criteria for T-waves in acute myocardial infarction. It is defined as T-wave inversions of greater than or equal to 1 millimeter in at least 2 anatomically contiguous leads. These leads must have they also have to have R waves present, or the R waves should be larger than the S waves, okay? So let's take a look at this criteria, okay? You can see here, these are actually ischemic T-wave inversions, okay? And the criteria is right at this point, okay? So at least 2 anatomically contiguous leads with T-wave inversion of at least 1 millimeter, okay? Here's our inverted T-waves. Notice that it's below baseline, certainly more than one of the small boxes. And also, we have to have an R wave, or the R wave must be greater than the S wave. So we have an S wave, so here's our R wave, and this is the end of our S wave, okay? So our R is certainly greater than our S, and we meet the criteria here, okay? So hopefully that makes sense. Those are considered ischemic T waves. Now, if you recall, there's something called hyperacute T waves. These are very large symmetric T waves with a broad base. They appear within seconds after total occlusion of a coronary artery and usually resolve within minutes, whereby ST segment elevation follows them. Because they are so short-lived, it is uncommon to see them in actual clinical practice. So if you look here, we have our hyperacute T waves. Notice how tall they are, okay? And these usually come on really quickly within seconds after occlusion of the coronary artery, okay, but then they disappear within minutes. So oftentimes you may not even see them in practice unless it happens quite soon, okay. Now, hyperkalemia can also show these large T waves that are symmetric, similar to the hyperacute T waves. However, in hyperkalemia, the T waves have a narrow base. And just so you're aware, there's one exception to these hyperacute T waves not lasting long, and that's De Winter's sign, which we'll discuss in another lecture. They tend to last even longer, okay? So again, here we have these symmetric T waves, okay? If you were to draw that, you'd see both sides are symmetric, okay? And they also have a broad base down at the bottom, which differentiates it from hyperkalemia. All right, so moving on. So it's important to keep in mind the non-ischemic causes of T-wave inversion, which we would consider secondary T-wave inversions, okay, because they come as a consequence of some other cause. Some of these include right or left ventricular hypertrophy, right or left bundle branch block, ventricular preexcitation, like with the delta wave in WPW syndrome, pacemaker stimulated rhythms, and so forth. All of these conditions have abnormal ventricular depolarization, which then leads to abnormal ventricular repolarization. And remember, abnormal ventricular repolarization appears as changes in the ST segment and T wave, which we refer to as secondary ST-T changes. As a side note, T-wave inversion may actually persist for some time even after the depolarization normalizes. And this is what we call T-wave memory, okay? And it's typically seen with patients with pacemakers. There will continue to be inverted T waves even when the beats are not paced, okay? So you pretty much this T-wave memory down here, okay? So you have T-wave inversion that continues to persist, okay? So normally if the depolarization normalizes, maybe you'll also see the repolarization phase also normalize in such that the T-waves would come back to normal. However, if the depolarization normalizes but the T-wave inversions persist, that's what we call T-wave memory, okay? And this tends to happen with pacemakers. Now, cerebrovascular accident, or CVAs, okay, such as with intracerebral hemorrhage, so bleeding within the brain, can produce a pattern that shows deep or gigantic symmetric T-wave inversions in the precordial leads, V1 through V6, and sometimes even in the limb leads. The QT interval may also be prolonged in such cases. And lastly, hypertrophic cardiomyopathy can produce deep isolated T-wave inversions in leads V2 through V5, which are typically accompanied by an increased R and S wave amplitudes. All right, let's review what we discussed before we end here. So we started off by looking at the normal T wave, okay? So remember, normal T waves are asymmetric, they have a steeper downslope and concordant with the QRS complex with a smooth ST to T transition, okay? The amplitude tends to be less than or equal to 5 millimeters in the limb leads and less than or equal to 10 millimeters in the precordial leads. Remember, greatest in V2 and V3, all right? And we said it's proportional to the QRS amplitude. And then we talked about these upright and inverted T waves. Remember, we define them by the terminal portion of the T wave, and that also applies to the biphasic T waves, where we saw this negative portion was a T wave inversion, okay? Now, isolated T wave inversion, remember, that means you have T-wave inversion without any ST segment deviation. This does not suggest ischemia, except in this one case which is Wellen syndrome, okay, and we'll talk about that in another lecture. Now, in terms of post-ischemic T-wave inversion, this occurs after ischemia, okay? It doesn't mean that there's ongoing or acute ischemia occurring, okay? So it confirms that ischemia occurred, all right, and you may also see a negative U wave, which would increase the likelihood that you had ischemia in the past. Now, often this will resolve within days to weeks, but if it persists for over a year, we call it chronic, okay? Now, if you have normalization post-MI, meaning that you have these post-ischemic changes, okay, and then they come back to normal, that may also suggest a repeat MI, okay? And we'll talk about that when we talk about T-wave pseudo-normalization. In terms of the ischemic T-waves, these are when they're symmetric, okay? This is abnormal T-wave inversion. It rarely exceeds 10 millimeters in depth, okay? You can also have those reciprocal changes like you see with the ST segment in ischemia. The EKG criteria, which we mentioned here, you need at least 2 anatomically contiguous leads with T-wave inversion of at least 1 millimeter deep, and then you need also an R wave or an R wave greater than the S wave in that lead, okay? In terms of these hyperacute T waves, also a sign of ischemia. Remember, they happen right after occlusion of the artery, so sometimes and oftentimes we don't even see them, okay? They're large symmetric T waves with that broad base. Remember, with hyperkalemia, okay, we had a narrow base, okay? And there's an exception where they tend to last longer, and that's winter sign, which we will also discuss in an upcoming lecture. Now, in terms of non-ischemic T-wave inversion causes, there's a number of them mentioned here. We talked about ventricular hypertrophy, bundle branch block, pre-excitation, pacemaker stimulated, okay? Remember, if you have abnormal depolarization, that leads to abnormal repolarization, and those are the secondary STT changes, okay? We talked about T-wave memory, cerebrovascular accident, intracranial hemorrhage as an example, okay, as well as hypertrophic cardiomyopathy, where you can see these deep isolated T-wave inversions in V2 through V5, as well as sometimes an increase in the R wave and S wave amplitudes. Well, that's the end of this lecture. We discussed T-wave changes in acute myocardial ischemia, including a review of normal T-waves, isolated T-wave inversion, as well as ischemic and non-ischemic T-waves. I hope you learned something.